Good morning, everyone. Good morning. Thank you for being here. In the interest of time, I think I will get started. Welcome to Centro SOL's first conference on Latino health. As many of you know, Centro SOL was established in 2013 by a group of faculty members who wanted to improve healthcare and opportunities for Latinos through education, research, clinical care, and advocacy. And everything we do in partnership with our Latino neighbors. At Centro SOL, one of the things that we believe firmly is that health is a human right, a right of all individuals, regardless of age, gender, race, ethnicity, socioeconomic status, country where you were born, or neighborhood where you may be born. This, of course, is not a new concept. The WHO espoused this concept of health as a human right in 1946, and then it was also adopted by the Universal Declaration of Human Rights in 1948. And since then, many other international conventions and organizations have talked about this right to health. However, we know that many health disparities still persist, even in countries that are very wealthy, like the United States. In fact, this country, which has the highest per capita spending for health than any other country in the world, still has huge issues in terms of accessing basic primary care. And many in administration have tried to address this. As we know, President Obama's Affordable Care Act has done an enormous amount, and it's probably the biggest health reform in decades. And there have been huge benefits because of that. Since 2013, about 16 million new people have obtained insurance through the insurance exchanges and the ACA, and the uninsurance rate has declined from 18% to 12%. But those of us who work with immigrant communities know that there's an enormous gap. And we still struggle to provide care to patients, especially those that are not only immigrant but also undocumented, while we are trying to meet all these other needs, like cutting costs and maybe even making a profit. We know that the issues are really complex, and it's really not that simple. And sometimes when you have a patient in front of you, it seems like there's nothing you can do, and that the issues and the challenges are really insurmountable. This is why we're having this conference. About a year ago, the Urban Health Institute actually asked us to start thinking about having a conference on Latino health. And we had multiple community forums to try to identify which was the topic that we should cover during this conference. And over, we heard the same thing loud and clear. The topic of number one priority for the Latino community here in Baltimore was access to care. Today, we have a wonderful group of speakers that have generously offered their time, and we'll hear about the issues that, in terms of providing care for immigrant populations from the policy area, from economics, diversity, and providing care. We'll start with an overview, looking at sort of the national level policy. Then we'll hone down a little bit on Maryland. And in the afternoon, we'll really talk about programs in Baltimore and the surrounding areas and how we're trying to fill those gaps despite all the barriers. The other thing we'll do is, towards the end of the conference, is try to identify steps forward and things that we can be doing. So I encourage all of you to really listen actively, to take notes, to ask questions, to really participate and think of ways that whatever you hear today, you can bring back to your programs, meet other people, exchange ideas. And I think together we can really make a difference. The other thing I would ask you to do, I think all of you in your folders have feedback sheet. So please give us feedback. You can grade our speakers, but more importantly, jot down ideas of things that we as Centro SOL should be doing, because we'll read them all. And I can tell you that the best work that we do at Centro SOL has always come from ideas that have come from the community. So please, if you hear something, and please let us know what you think. Also, you can give us ideas about what future conference should be about. So I want to thank, there's so many people that I could thank, and I'm not going to thank everyone individually because I think it would take a long time, but I think everyone who knows who I'm talking about, basically. I will say one thing, there's a couple big supporters, in particular the Strauss Foundation and then the Urban Health Institute, who were really instrumental in sort of pushing us to do this conference and to mentor us as we organize this. I want to thank the community-based organizations that are partnering with us, many of whom will be speaking here a little bit later on. I want to thank all our speakers for coming from far and not so far, and sharing your thoughts, and also for all the work that you do in health equity. I particularly want to thank all of you guys for being here and caring about this, and for the work that you do as well. And then there's just a few people, 3 people that I feel like I have to thank personally. And one of them is right here, Sarah. Sarah is a pediatrician and highly committed to Latino health. She is the medical director of the Bayview practice and has increased the number of Latino patients, I think that they see, to like 80% or so. She's also been my partner in crime organizing this and has been very fun to work with. Jen Rivets, I don't know where Jen is. Is Jen somewhere there? Who really was the first believer and supporter of Centro SOL, and Centro SOL would not be here without Jen and her support. And then last but definitely not least, do not walk away, Monica. Monica, can you raise your hand there? Monica has been doing all the work behind the scenes, and we all know that she's the heart and soul of Centro SOL. Everyone knows Monica, and we really thank you for everything that you do. So with that.
Thank you, Kathleen. It's now my pleasure to introduce today's keynote speaker, Dr. Benjamin Sommers. Dr. Sommers' education provides a clear roadmap for a career not only in research in health and healthcare, but advocacy in health and healthcare. I would wish that for him if that's not actively what he's already doing. He received a bachelor's degree in English at Princeton, providing preparation for written argument and persuasion, a doctoral degree in health policy with a concentration in economics from Harvard, providing both knowledge and bona fides, which are not always mutually inclusive in the business of both health and healthcare. And then finally, he received a medical degree in internal medicine training at Harvard and at the Brigham and Women's Hospital, which surely taught him the human side of health and the shortcomings of America's healthcare system. Dr. Sommers is an assistant professor in the Division of General Internal Medicine at the Harvard Medical School. He provides primary care to adults at Brookside Community Health Center in Boston. His research interests are made clear by the titles of some of the prestigious grants he has been awarded, evaluating coverage, utilization, and access to care in Medicaid early expander states under the ACA, early impact of the ACA on low-income populations, and Medicaid policy coverage and access to care among low-income Americans under health reform. Finally, our attention was particularly drawn to an article written by Dr. Sommers on the implications of Obama's executive action on health care for immigrants. His description of the uninsurability of some immigrants is particularly distressing when compared to his work on the mortality benefit of Medicaid expansion. Please join me in welcoming Dr. Sommers.
Thank you, Sarah, for the introduction. Everyone can hear me okay? Yes. All right. People in the back, raise your hand and wave at me if I start drifting away from the microphone and you can't hear me. All right. So I want to thank Johns Hopkins and the Centro SOL and the Urban Health Institute for having me here. The talk today entitled Immigration and Health Policy at a Crossroads. I think we're at a pretty distinctive time for both issues related to the U.S. policy on immigration and also our healthcare system. There's so much going on and so much change that's already happened and so much more that's on the table, but major gaps or shortcomings in those policies that still need to be addressed. And I'm going to try to do this without a lot of slides. That was Kathleen thought that sounded like a good idea. Try to keep you engaged. There'll be a couple of pictures and figures here and there, but for the most part, I'm going to try to tell a little bit of a story that walks us through these different domains, through immigration, through health, and then through healthcare. And health and healthcare are not synonymous. We often use them that way, but obviously there's some important distinctions. But to start with, I thought I would just give you a little sense of why I have come to feel that this is such an important issue, not only in my my research work, but personally and in my kind of my role as a doctor. This is my clinical home. This is Brookside Community Health Center. For those of you who know Boston, this is in the Jamaica Plain neighborhood on the edge of Roxbury. Our community health center serves about 70 to 80% people of Latino ethnicity, probably about half of whom are primarily Spanish speaking, large numbers of immigrants and first generation Americans, and it has become just a daily part of my clinical practice to think about issues that go far beyond what we get taught in medical school, to think about barriers that are cultural, that are legal, that are linguistic, that are economic in terms of people's ability to get the care that they need. And this is in Massachusetts, which in many ways, and I'd argue in most ways, is really far ahead of the rest of the country and on average in terms of promoting affordable access to health care. We have a universal health care law or near universal coverage law passed in 2006. We have a generous safety net system in place for providing coverage for people who don't qualify for other types of insurance through Medicaid or private insurance. But even so, it's essentially a daily occurrence that patients being seen in our clinic have challenges to getting the care they need. And so if that's happening even in a place like Massachusetts, I often think to myself with distress, what is the reality like for patients in other states, in other settings, and the problems are just magnified dramatically. So to start with, when we think about this crossroads of immigration and health and healthcare, I think it's worth stepping back and briefly thinking about what do we mean when we talk about the population of immigrants in the United States. I think almost everyone in this room almost certainly recognizes how heterogeneous a group this is, and that there really isn't one group. I think in the average person's conception when they hear immigrant, they think about someone from Mexico crossing the border, living in the Southwest United States. That is a pathway of entry into the U.S. and a group that is a really important one because it is large. It is a significant component of the U.S. population of immigrants. But the heterogeneity is so much richer than that and is really important when we start thinking about not just legal and policy approaches, but cultural engagement, community outreach. And so when we think about the community of immigrants or the communities of immigrants in the United States, it's worth stepping back and reminding yourself of a couple facts. So first off, that if you look at the foreign-born population of the U.S., that only 50% is Latino from Latin America or the Caribbean. And meanwhile, large numbers of immigrants from South and East Asia. In particular, if you look in Southeast Asian immigrant communities, there are large numbers of people facing significant economic distress, issues of political asylum, human trafficking. And in other communities, there are unique challenges within each group by origin, by legal status. And so this isn't a monolithic group of people by any stretch of the imagination. And so our approach to thinking about how we address the policy challenges and engage with these communities needs to be sensitive and multifaceted. So when we think about immigrants in the U.S., legal status is one very important aspect to take into account. As a rough rule of thumb, when you think about the people in the U.S. who are not born here, foreign-born residents of the U.S., they roughly divide into three categories, very roughly. The first category are naturalized citizens. About a third of foreign-born people in the U.S. Have gained citizenship, and from a policy perspective are essentially eligible for all the same programs and social services as U.S.-born citizens. But that doesn't mean that there aren't particularly still issues related to cultural attitudes towards health care, language issues, and as I'll kind of go on to describe, naturalized citizens often are embedded in families and communities where other members with different legal status are present. So the next big group are people with legal permanent residency status, the people with a green card. And this is, again, roughly about a third of the foreign-born population. Here we start to encounter some of the legal barriers to social services. While here legally they are not eligible for some of the same programs, I'm going to go into a bit more detail as we go, but there's a set of different standards and rules that apply to legal residents as they might try to access the healthcare system or obtain coverage. And the third big group, legally speaking, are undocumented immigrants. Depending on what data source you look at, and you can imagine this is somewhat challenging to measure well, the Census Bureau estimates about 10 to 11 million undocumented immigrants are currently living in the U.S. And here's where we reach the group that has by far the most legal barriers to any kind of access to our healthcare system, significant by design discriminatory statutes that say this group can get and this group cannot get access to these social services and the like. Now, there is a small group that isn't in that one-third, 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 which is typically overrepresented in a place like Johns Hopkins or in any university setting, which is people here, legal status but not permanent residents, student visas, work visas. I throw this in as a mention because not only is it often the status for people in the room, it's also plays an important role in healthcare. If you look at the workforce in a lot of low-income settings, and in particular in rural settings, it's in fact non-U.S. providers who provide a disproportionate amount of that care. Through programs like the J-1 visa waiver, you have a large number of people on temporary visas from overseas who provide care in some of our most vulnerable settings. And so that is a part of the story of how we think about immigration status and healthcare. So having laid out these three categories, though, what we have to recognize is that these boundaries are artificial. Right? They are legally constructed, but households and communities don't follow them. Right? So you have families and households where it's quite often the case that parents are here undocumented and their children were born in the U.S. and are U.S. citizens. Or you have an older sibling who is undocumented and a younger sibling who's a citizen. You have multiple families living in a household together where one set of families, the parents have their green cards and legal status, and meanwhile they live with a brother and sister-in-law and their kids who are undocumented, and they're all in the same household. And so this has really important implications because it means that policy in any one group by legal status has significant effects on other members of not only the community, but even the households of the people being targeted by those policies. So I'm going to kind of talk through that there are both negative spillover effects, but sometimes positive spillover effects depending on the laws that we're looking at. And it's important to kind of keep that in mind. It also makes the implementation of these laws more complicated and requires much greater cultural sensitivity and community engagement because there's an inherent suspicion or distrust that can exist whenever you have policies in effect that have different impacts on different members of the same family. So it's also a really important political consideration to keep in mind. I think sometimes when you look at, for instance, we're getting ready already to approach another presidential election season, and we're starting to see the articles discussing how immigration will play into the campaign and outreach to different communities. And one of the frequently discussed points is how high a priority the Latino community places on immigration reform. And I think you can't understand that if you don't understand this kind of crisscrossing legal status within households and communities. Some of this is ideology and kind of a belief system about what is right. Some of this is about ethnic solidarity, but a lot of this is about I live and work, or I have a family member who's directly affected by the threat of deportation, and this looms over everything that happens not just for him or her, but for multiple members of his family and extended circle. And so that becomes an issue that isn't just about undocumented immigrants. It's really about an entire community of people who are immigrants and family and friends and colleagues of immigrants. And that's, I think, something that we really have to keep in mind and not fall prey to too much of this artificial distinction that the law creates. Okay, so then moving from immigration into thinking about health. Now, many of you may be aware of this concept called the healthy Hispanic paradox. So I'm going to talk a little bit about this because I was actually preparing my notes for the talk this week when I saw an article last week come out that the Centers for Disease Control and Prevention, the CDC, had put out a new report. And in fact, the director, Tom Frieden, had a press calling where this is basically what he talked about, how the good health, the surprisingly good health of the Hispanic community in the U.S. And this is really an interesting concept, but it really requires a fair bit of unpacking to understand what it does mean and what it doesn't mean and what the implications are for public health and for health policy. So let me show you a couple of the infographics that the CDC released in this report. This was one of them with the faceless but color-coded silhouettes at the top. So for several major causes of disease, some of the leading causes of death and disability morbidity in the U.S., if you compare the rates for Hispanics versus non-Hispanic whites, you see that there are actually lower rates. So heart disease, 8% for whites, 5% prevalence for Hispanics. Cancer, half the rate in the Hispanic community. Blood pressure, high blood pressure rates, slightly lower among the Hispanic community. And this is true across a whole host of conditions, including mental illness, obesity, and other health behaviors as well. And you put it all together and you get this really startling finding that overall, the death rate, if you look kind of by age and you look at the incidence of death across racial and ethnic groups, that Hispanics are dying at 24% lower rates than non-Hispanic whites. Okay? So that's the kind of headline that gets captured in the CDC report and the media conference on the healthy Hispanic paradox. So those statements are all true. I'm not going to try to tell you that they're not true, but let me try to give you more context and understand some of the, I would say there are really three large caveats that are important to keep in mind in interpreting this and saying, well, then what do we do about it from a public health perspective, right? Because one flippant conclusion from this would be, oh, well, I guess there really isn't any issue in healthcare for Hispanics. Well, I think all of us can agree that that's not the case, and let me talk about how to interpret this. So the first thing to think about is that the distribution of who is in the U.S. and who immigrates to the U.S. is not random, right? It's not representative of the general population in countries that people move from and that just some of them happen to move to the U.S., right? Immigrating and entering the U.S., whether legally or through, as an undocumented immigrant, is itself a very high hurdle for physical and mental health. Right? Getting in and acquiring legal entry into the U.S. Typically requires much higher levels of social capital and connectedness, of being informed about the process, typically on average higher levels of education and employment opportunities, and then probably even more so if you then shift into thinking about who enters the country as an undocumented immigrant, and you think about the conditions and the challenges that entails. People who have major medical problems are much less likely to be able to complete that process. People who have major mental illness are much less likely to complete that process. What's the single most common reason people move to any country but move to the U.S.? Employment, right? Employment opportunity. Well, who moves for jobs? People who can work. So people who have significant disabilities, or physical or mental disabilities, are much less likely to then migrate. And so you take that, you're getting a selection pressure for the healthiest people moving in. And then, at the other end of the lifespan, we see the opposite factor. It's a phenomenon in some communities where as people are past the working age and if they develop significant illnesses and are potentially life-threatening illnesses, that there is some selective exit where people go back to their home countries. I see this in my clinical practice. And there are a lot of reasons for that. Some of it is people want to go back to where their extended family is, or they want to go home to die and be buried in their home country. But some of it's also economic, right? If you live in a country where healthcare is more expensive than it is anywhere else in the world, and where many people by their legal status are systematically excluded, it makes sense that when they get sick, they're going to go home to get care elsewhere, which is, in some ways, the ultimate indictment of the disparities in our healthcare system. But so you get this selective exit as well of people who are sicker than leaving these communities. And so those can both produce a significant bias in these numbers, the way that the disparities or these positive paradoxical results show up. The other things, the other two caveats I'd add here is to think about the time course. As people and families stay in the U.S. longer, this healthy paradox starts to wane. So for instance, if you look, this is more information from the CDC, from the same report. If you look at Hispanics who are born in the U.S. versus who immigrate here, who were born elsewhere, over the subsequent generations, people do worse. So you see that cancer rates among the foreign-born, those who have immigrated here, 1.4%, nearly double among the next generation and subsequent generations that were of U.S.-born Latinos. Heart disease, similarly, much lower among those who moved here, and then subsequent generations, higher rates. And it's not just these chronic diseases, it's the risk factors. Obesity, now 36% obesity among immigrants isn't a great number either, but it gets even higher. Nearly half of US-born Hispanics are obese. And then cigarette smoking goes up dramatically, from 10% to 17%. And so what this says is a couple of things. The first is living in the US isn't that good for you. That there's an acculturation process where people pick up habits that are not good. You get more sedentary lifestyle, you get worse diets, you get more smoking. And so this causes a part of this. Well, the other piece of this, though, is also that while the immigration process itself is that selection force for healthy people and healthy behaviors, subsequent generations aren't subject to that same pressure. And so you start to see just kind of an increase in chronic diseases and other behaviors. And so conclusion one from that is, yes, the U.S. acculturates you in ways that isn't healthy for you. And the second conclusion here is that over time, this healthy benefit starts to go away, and what we start to see is a rise in the kinds of chronic diseases, the kinds of health behaviors that are going to produce major limitations in health and in mortality that we then need to think about what's the system in place to treat people when they develop these problems. And then finally, the third caveat I'll add to the healthy paradox notion is that even if healthier on average, the Hispanic community, as I'll talk about shortly, experiences huge disparities in their ability to access healthcare, regardless of their health status. And so even if you remove solely a focus on health outcomes, if we think about process and we think about social justice and discrimination versus health equity, then we should see that fundamental disparities in access, even if they're not always showing up in worse health outcomes, should still be of concern to us. So let me then turn now from health into healthcare, which is really where I spend the bulk of my time professionally and in my research, and where the disparities for the Latino community become really impossible to ignore. So when we think about access to healthcare, I have kind of in my own head and a model that was written by John Eisenberg about 15 years ago that maps how you can go through various barriers in the healthcare system and lose the ability to get the care that you want, and that I think many of us would argue that everyone deserves. And the first step in that process of encountering barriers is health insurance, health coverage. We know from a host of studies that gaining access to health insurance is essentially a prerequisite for being able to afford and get consistent health care that improves the quality and the outcomes of healthcare. So let me give you a couple basic statistics here that make the disparities quite jarring. So Kathleen mentioned that the uninsured rate among the U.S. general population is now actually down under 15%, depending on what numbers you look at, 12 or 13%, which is the lowest it's been essentially since any surveys have collected data on this. The numbers for U.S.-born Latinos, who are by definition U.S. citizens and therefore eligible for all the programs and every in the healthcare setting, 25% uninsured rate. So and that's among U.S.-born Latinos. You go into the undocumented population, and the number is 60% by one estimate. Okay, so just jarringly high rates of people who simply have very little or no way to pay for their health care. And then this plays out as you'd expect. If you look at the percentage of people who have a primary care provider, a regular source of medical care, it's more than double. More than double the number of whites in the Latino community that don't have one. So 40% of undocumented Latinos have no regular source of medical care. And now some people will say, well, that's fine, they go to the emergency room. They don't, actually. If you look at studies by immigration status, immigrants are much less likely to go to the ER than other groups. Now, they're much more likely to have nowhere to go, and so they, of the care that undocumented immigrants get, they get a disproportionate amount in the ER. But if you look at their overall use of the ER, they just don't use much of any health care in the same number as U.S.-born population. So Latino immigrants, undocumented immigrants in particular, very high rates of no primary care, lower rates of utilization across the board. And then, not surprisingly, this starts to play out that you get less of the recommended care. We get less preventive care that would be the kinds of care that we would really hope would improve quality and length of life. And in addition to the financial barriers, we know that there are significant cultural barriers and linguistic barriers as well. So it's not just health insurance, though as a policymaker, that's often where I start because A, it's such a big glaring disparity, and B, it's actually easier to fix this problem than the other, right? It's easier to give people health insurance than to eradicate cultural barriers and linguistic challenges. And in some ways, you get rid of the first barrier, which is let's get people covered, and then we have to figure out how to provide care in a culturally competent, sensitive manner. So that's kind of the disparities that I think motivate why you need a conference like this, right? This is, if we just stopped with the healthy Hispanic paradox, we would say, great, then we don't need a conference, but we clearly do. So what is the legal framework? What's the policy framework then when we think about health policy in the U.S. for immigrants, and in particular for undocumented immigrants? Well, the first off is thinking about Medicaid. Medicaid is now the single largest source of coverage by plan. About 70 million Americans have Medicaid, more than any single insurance company, more than Medicare. But it systematically excludes undocumented immigrants essentially entirely. I'll talk a little bit about something called emergency Medicaid, but for the most part, undocumented immigrants cannot get Medicaid. And even if you're a legal permanent resident, you have to have been here for 5 years before you can qualify for Medicaid. And so what that means is that we have created essentially a 3-tier system for the program that is thought to be the kind of insurer of last resort. And that there's a whole class, 10, 11 million undocumented immigrants who are just not eligible at all. And then we have another population of legal immigrants who, if they haven't been here long enough, are still out without an option for Medicaid. Why does that matter so much? Well, if we look at the employer-sponsored insurance world, which still provides in total, if you take all the different types of employer coverage, still covers more than half of all Americans. So it's still a key, critical part of the healthcare landscape. Employer-sponsored insurance is disproportionately unavailable to Latinos in general, but specifically immigrants. And why is that? It's a couple of different factors together. First is employment, whether you have any job at all, but particularly the kinds of jobs. So if you look at the fields that Latinos, and in particular Latino immigrants are employed in, they're disproportionately likely to be lower income, disproportionately likely to be in service industries or agriculture, where it's almost unheard of in many cases to be offered comprehensive benefits along with work. And in the cases where you are offered those benefits, if your income is too low, you almost certainly can't afford your share of the premiums. And so because of this, employer-sponsored insurance rates are significantly lower in the Latino community than in other groups. What about Medicare, which is the country's universal program for insurance for the elderly? Well, it's near universal. 98 to 99% of people over 65 have Medicare, but it's not automatic. So the people who are not eligible for Medicare are undocumented immigrants, again, law is very clear that they're not eligible. And then there's actually a requirement that most people don't think about. We kind of think of Medicare as being automatic at 65. You can get it earlier than that if you have a long-term disability. But to qualify for Medicare, you have to really meet one of 3 criteria. The first is that you've paid into the payroll tax system. And you actually have to have paid in for 40 quarters or 10 years to qualify kind of for full Medicare benefits upon retirement. Now, either you have to have done that or a spouse has done that. And the third category is if you have a long-term disability. Turns out that if you're born in the U.S. and live here, it's very hard not to be in one of those 3 groups, because either you've worked, your spouse has worked, or you couldn't work, presumably because of a disability, and you qualified that way. So that's how you get 98 to 99% of the elderly with Medicare. Who doesn't meet that criteria? Well, people who move here, especially people who move here late in their careers or after they're done working. So, I always bring these back to thinking about individual patients of mine that help me kind of think what's the reality. So I think of my patients who, a delightful couple in their 70s who moved here from moved to Boston from the Dominican Republic so they could live with their daughter and their grandchildren. They were done working. They got here, they're here legally, but they're not eligible for Medicare. Right? They have not paid into the system. They don't have the disability qualification. And so while 99% of the overall population over 65 has Medicare, one study in New York City, a city with a lot of immigrants, estimates that about 10% of that city's population doesn't qualify for Medicare because of this. So you take these factors together, and that's how you get these big disparities. But we're now on the cusp, where we're actually a year into the biggest change in our healthcare system since the creation of Medicaid and Medicare in 1965. So now we're in year 2 of the full implementation of the Affordable Care Act. So all of this is now changing. A lot of this is now changing, not all of this. And so understanding kind of how this plays out in the different groups within the immigrant community is really important for understanding what the law is doing and is helping and what it isn't doing. So first off, there are some real benefits of the ACA in the immigrant community and in the Latino community more broadly. The first thing is that 5-year waiting period for people with a green card doesn't apply for people who want to get coverage in the marketplaces. So the ACA basically expands coverage through expanding Medicaid, and I'll talk more about that in a minute, and through creating these new health insurance marketplaces that are one-stop shopping where you can compare plans and pick out an insurance plan, where they're not allowed to discriminate based on your health status, and depending on your income, you can qualify for pretty substantial tax credits to help you buy that insurance. And that's eligible for people with a green card, even if they have, just got their legal permanent residency status. They don't have to wait 5 years, and that's a big, a big change that they now have a federal program that can help them get coverage. There's also the expansion of Medicaid. So before the ACA, Medicaid, despite the kind of popular conception that it covers poor people, which is how most people think of it, covered certain groups of poor people, right? Even if you were here and had legal status and had, let's say a U.S. citizen, you could only qualify for Medicaid in most states if you fit into one of the following categories. You had to be low income with a disability, you had to be pregnant, a parent of a dependent child, or a child. People who were, say, 50 years old, no kids living at home anymore, either didn't have kids or kids had grown up, didn't have a disability, but was really struggling and maybe earning a couple $1,000s a year, well below the poverty level. Most states in the U.S. not eligible for coverage, not eligible for Medicaid pre-ACA. And then even if you were in one of those categories, depending on what state you lived in, the eligibility was quite different across states. And so, for instance, if you lived in Texas or you lived in Arkansas and you were a parent who had a kid at home, so you're in one of those groups that Medicaid's supposed to cover, if your income was $7,000 or $8,000 a year, that was too high for Medicaid. You had to have an income below to about 20 to 25% of the federal poverty level. So you have people earning $8,000, $9,000 who are at half of the federal poverty level who are considered too rich for Medicaid. So the ACA intended to change that entirely. As written and passed in 2010, the idea was every state was going to have to increase its Medicaid cutoff to 138% of the federal poverty level, up to $16,000 a year for a single person and about double that for a family of 4. And the idea here was that not only was the income threshold higher, it no longer mattered if you were in one of these categories. You didn't have to have a disability or have children in your home. If you were below that income cutoff, you were eligible, subject to immigration requirements, right? So you had to either be a U.S. citizen or have a green card for at least 5 years. Okay, that was how the law was passed. As many of you probably know, if not all of you, the Supreme Court came along and said, actually, this is not permissible. It's not constitutional to require all states to do this, so we're going to let them decide. And currently, 30 states, including Washington, D.C., have decided to expand, and we have about 20 states that haven't. And so we've seen big changes, and I'm going to show you some of the numbers in a couple of minutes, that Medicaid has become available to large numbers of Latinos and legal immigrants who have been here for the requisite 5 years, who just didn't meet criteria for the old Medicaid eligibility system, even though they often were low income and struggling to access health care. Okay, so those are some of the benefits of the ACA. And then there's some kind of lower priority items that aren't on the high headlines. The headlines of the ACA are, here are the marketplaces and here's Medicaid expansion. But there's some of these indirect effects, some of these spillover effects or smaller programs that are also really important to think about because they do change the options available to some immigrants. So there is something called emergency Medicaid, and it varies by state, but essentially the way it's set up is that if you meet your state's eligibility for Medicaid except for your legal status, you can get limited benefits that cover emergency room care and labor and delivery costs and any urgent inpatient hospital costs. It's not comprehensive health insurance, right? It doesn't let you see a primary care provider. It doesn't let you see outpatient specialists. It doesn't cover your prescription drugs. So it's not insurance. But essentially, I think of it as it's insurance for the hospitals. The hospitals have to provide that care when you show up on their door, so they get some money back. So it helps a little bit, but it is not a comprehensive solution by any stretch. That said, it's better than nothing. It keeps people who show up in the hospital with a catastrophic illness or injury from being saddled with the bill and going into bankruptcy. And so that is better than nothing. And the expansion of Medicaid offers that expansion as well for emergency Medicaid, because now if you're in a state that expanded Medicaid, more people will meet that eligibility criteria except for their documentation status. And then finally, a group that I think most people at first blush don't focus on with the ACA, because the ACA didn't change their eligibility for programs, but it's important to think about, are children. So in Medicaid and in the Children's Health Insurance Program, kind of Medicaid's companion program, we've done a great job in reducing the uninsured rate for children. It's declined steadily since the expansion of CHIP in the late 90s, and the risk of being uninsured among children is far lower than that for adults. But there are still large numbers, several million uninsured children, and many of them are actually eligible for public programs and are not signed up, or have been in the past but didn't stay in. So why does that happen? Well, people might not be aware of it, or people had trouble completing the paperwork process. They might have been in it originally, and then they got sent renewal materials, and they had moved and never got that material, and never got the mailing, or they couldn't read it and needed help filling it out. So there are a lot of reasons that might drive people who could be eligible for coverage, but kids that remain uninsured. And some of the steps in the ACA might help with that. And so the things that the ACA does that might have some positive effects for children in this area is, first off, the enrollment process was streamlined pretty significantly under the ACA. Now, that's not true in every single case, and Sarah and I were talking about this earlier, that there are some areas where that's actually maybe potentially worse now than it was before. But in general, the ACA changed several factors. When you applied for Medicaid before the ACA, your state was allowed to ask you what your assets were. They were allowed to say, well, what do you have in the bank? Do you have a car? How much is your car worth? Now, not every state did that, but states that did that had significantly lower participation rates. People had more trouble enrolling for coverage, not because they had a lot of money in the bank, but because they had trouble documenting that they didn't. Think about your car if you have one, and what you would need to do to provide clear documentation of that you own it and its value. Not a straightforward process, right? Especially if you don't have papers for them, or if you're language or other potential barriers. So the ACA said you can't do that. Except for people trying to get long-term care, you can't ask about assets. The states used to be able to come and send you a mailing every 3 or 6 months, say, fill this out, otherwise you're going to lose your coverage. You have to show us you're still eligible. The ACA says you can't do that any more frequently than every 12 months. And so that also can make a big difference. And finally, there are now, in the Medicaid expansion states, a whole group of low-income parents who previously weren't eligible for anything and now can get Medicaid. And studies show that when you cover parents, that you're more likely to cover their kids. That parents who aren't eligible for anything are less likely to sign up, because they have less awareness, or they get less help at their own doctor's office because they're not going to get coverage. If you get a whole family eligible, you increase the enrollment rates. So all of these are positive effects that spill over in groups that have high uninsured rates, like the Latino community. So these are some of the benefits, and I'll show you in a couple of minutes what the net impact of these benefits have been. But also I want to talk about missed opportunities and active harms that the ACA is causing. And to start with is simply that basically the law makes no change in the status of undocumented immigrants, right? That's the big glaring omission when we talk about the ACA as a law that's trying to target near universal coverage. The group that was never included in that umbrella for change is the undocumented immigrant community. And if people want to discuss that in Q&A, I'm happy to do that. Essentially, the way I think of this is the ACA survived about 7 or 8 near-death experiences before it was finally implemented into law, starting in 2014 with the full coverage expansions, and that was with a law that excluded undocumented immigrants. It's pretty likely to me that it would have died on its first or second near-death experience if it had tried to expand coverage in a meaningful way to undocumented immigrants. That's not to justify it one way or the other. That's just, I think, my take of its political prospects had it done something different. So that's the biggest omission. And when you have that in mind, some of the other things I'm going to talk about start to be more problematic. So, for instance, the ACA expands coverage dramatically and spends a lot of money to do it. But one of the ways that it tries to get some of that money back is saying, well, we have a lot of systems set up in our country that direct money into safety net settings through means other than insurance. Why don't we pull some of that money back, because now we're going to have a lot fewer uninsured people. So, for instance, one of the programs is called the Disproportionate Share Hospital Payments, DSH payments. These are lump sums that the federal government issues through states to hospitals that provide care for uninsured populations and a lot of Medicaid patients. And the idea here is to help cover some of the costs of uncompensated care. Well, it makes sense that you will need less of that if there are a whole lot more people with health insurance. At the national level, that makes perfect sense. The problem comes in how you distribute those reductions in payment, because we now know that 20 states aren't expanding Medicaid, and we also know that some hospitals are working in areas where they're getting less of a change in coverage. Fewer people signing up. We know a lot of states had marketplace websites that didn't work very well. We also know that some hospitals treat a disproportionate number of undocumented immigrants who were left out of the ACA. So the distributional effects of these cuts in funding might have real implications for the immigrant communities in some of these places. We also have the issue of outreach. So the ACA spends a lot of money to help people do outreach and enrollment assistance, but those funds are not allowed to be spent on undocumented immigrants. And so to the extent that providers that used to do a lot of outreach and enrollment aren't able to do so or aren't doing so, this could have a negative kind of unintended consequence or spillover effect. And I thank Sarah for kind of bringing this to my attention and thinking about how it's playing out in their clinic. And then if you think about the biggest hole in the ACA, in my opinion, at least in its current implementation, is that 20 states just aren't doing the implementation the way the law was written. So if we look at a map of the Medicaid, if we look at a US map and we think about which states are expanding, which aren't, we see that it's not, unfortunately, evenly distributed. And so this is a map from the Pew Hispanic Center that shows the percentage of each state's population that's estimated to be undocumented immigrants. And if I were to replace this map with a overall immigrant population, regardless of the legal status, it looks pretty similar. And also, if I were to replace this map with percentage of the population that's Latino, the maps look fairly similar. And in any of those maps, what would stand out to you if you were interested in access to care for low-income people are these states. So Texas and Florida, home to the largest numbers of uninsured people in the country, and huge numbers of Latinos, and in particular immigrants and uninsured undocumented immigrants, not eligible for Medicaid under the ACA, regardless of legal status, not eligible for emergency Medicaid under the ACA. And you also see that the states in the South, where we don't typically think of having large numbers of immigrants, do have growing immigrant communities, and essentially none of these states are expanding Medicaid. The only the states in the South that have expanded coverage so far are Kentucky and Arkansas, and in those two states we've seen huge reductions in the number of uninsured people because there was so much need to begin with. So we have this unfortunate mismatch or match, depending on how you view it, between where we have a lot of uninsured people, where we have a lot of immigrants, and which states are not fully implementing the ACA and are not expanding Medicaid. Okay, so taking all of these, these effects, the benefits and advantages of the coverage expansion that I mentioned earlier, and then some of these big gaps in the law or the law's implementation, where does that leave us? So if we look at the evidence so far, and this is from some data that we analyzed from last year after the first open enrollment period. So this was over the summer of 2014 when the healthcare.gov fiasco had come and gone, the website was working, people were able to get signed up. And what you see here is look at the right-hand column, the second quarter. This tells us the change in the uninsured rate by the end of that open enrollment period compared to the baseline trend and adjusting for the economy and demographics and that sort of thing. And what you see is the biggest number in that column is for Hispanics. So large reduction, 7.7 percentage point reduction in the uninsured rate among Hispanics. So at first pass, I'd say, wow, this shows you how much of those pros that I mentioned, the benefits of the ACA with Medicaid expansion, marketplace coverage, the tax credits available to legal permanent residents, really making a dent in the uninsured rate. But then I want to draw your attention to the first column, which is the baseline uninsured rate. This is the percentage of these populations that were uninsured pre-ACA. And now the story gets a little more complicated because that 4 percentage point reductions for whites was coming off a base of 14% uninsured. So nearly 1/3 reduction in the uninsured rate in that population. Meanwhile, in the Hispanic community, it's only about 1/5. Right? So the story here, it's two lessons. One is the kind of important policy lesson. The other is kind of thinking is using a critical eye for statistics. But for the policy lesson, it's yes, the ACA has made a lot of improvement in covering people in the Hispanic community. But the flip side is there's still so much need, right? This drops us only into the 30s, right? So we still have about 1 in 3 people in this age group, this is the 18 to 64-year-old age group, that are uninsured. So there's so much more to go, and so that year one of the ACA shows us that this law can do a lot of good, but we have a lot of work left. Now, if your reaction were, well, that's because they're undocumented and they can't get it, that's not true, right? The undocumented proportion I told you is about a third, and of them, 40% actually have coverage. So this, even if you removed the undocumented immigrants from that population, you'd still have an uninsured rate over 20%. So there's still a lot of people who are probably eligible for coverage. And this is where I get to kind of thinking of what are some of the take-homes that are practical for people in the audience who work and kind of in this community. So information barriers are still enormous, right? Rather than focus only on the fact that the ACA doesn't cover undocumented immigrants, which is true and something that needs to be discussed and addressed, there are still huge numbers of uninsured Latinos who are eligible for coverage and either don't know about it or have been unable to get enrolled. And that's true despite these year one successes. And in year two, we're seeing that the numbers continue to climb, but they're still, the curve is starting to flatten a bit, which is not unexpected. I kind of think over time expansions often do that. So there's a lot of work to be done, and community outreach, education, and assistance with enrollment can play a huge role. The other point is simply for those of you who spend your time reading papers and thinking about statistics and thinking about the language of disparities. You can tell whichever story you won here. You can say, look, we had a larger absolute reduction in the uninsured rate for Latinos. The law is closing disparities. Or you can say, what percent reduction in the uninsured rate did we accomplish? This is making things worse. Disparities are getting worse. The truth is that neither of those one-liners really captures it accurately. Right? You have to look at both the absolute change and the relative change to make sense of what you're seeing. And so I would say that the ACA is covering, compared to the overall population, more Latinos than it is in other groups. But the need is so much greater that we still have more work to do. So now I talked a lot about federal policies. I do want to stop because I know as a segue towards where we're going in the afternoon to think a little bit about how states play a role in here other than through deciding whether or not to expand Medicaid. So while there are these federal prohibitions on how Medicaid dollars get spent, states can do whatever they want with their money. So if a state decides that they're going to cover undocumented immigrants, they're allowed to. They can't spend federal Medicaid dollars to do it, but they can spend their own money. And every once in a while, some states do this in some limited way or more expansive ways. It's often hard to sustain politically and economically without federal government support. But for instance, right now, California is debating Senate Bill 4, which would expand their state's Medicaid program, Medi-Cal, to cover undocumented immigrants as well, where undocumented immigrants would be covered purely with California tax revenue. Right? Whether this passes, it's hard to say. The political obstacles are always quite large. And for the state, it's always very hard to maintain funding in recessions because states can't deficit spend, and the federal government can. And that makes it really hard to keep this as a sustainable path. But when you think about kind of advocacy opportunities, states can do more, as can localities. There's no federal restriction on states and counties spending their own money on what they want to spend it on. They just can't get that federal match, which is really important. So then the last thing I want to talk about as we think about healthcare and immigration at a crossroads is immigration policy itself and how it plays out in healthcare. So I imagine everyone here is familiar with the president's executive order announced in the past year, DAPA, the Deferred Action for Parents of Americans and Lawful Permanent Residents, currently held up in the courts in litigation, unclear how it will play out. But what would DAPA do if implemented in terms of healthcare? It's not a healthcare policy. It's not designed, at least explicitly designed, to change the fundamental legal barriers to participation in our healthcare system. But here's where you have to think about spillover effects, because even though the law isn't targeting health policy, there are actually some pretty significant impacts that would play out in the healthcare system if this policy goes into effect. So first off, the policy includes so it's granting deferred action, so removing the threat of deportation from about 5 million undocumented immigrants, so not everybody, but about half of the remaining population of undocumented immigrants, and also offers the opportunity for work permits for authorized employment. And when you think about what comes along with employment and potentially greater employment opportunities with legal employment, is health benefits, right? So if you're able to get higher paying jobs or you're able to have a bigger paycheck that lets you take advantage of an employer's offer for coverage, we might very well see significant increases in the number of immigrants who are able to get private coverage under this policy. And that has big impacts not only for the immigrant targeted by this policy, but family members, children or spouse that might be here legally but previously couldn't afford coverage. The White House has also suggested, at least one spokesman issued a statement saying that their reading of the law was that if a person with a work permit paid into the Medicare payroll tax system for long enough, they could get Medicare after the requisite payment period. If this plays out, while in the short run this won't do much because it takes a while to pay in, but after 10 years, 15 years, this opens the door to having a large number of people gaining Medicare as they turn 65 or if they develop a disability after working for a while in the US. And so this could make a big difference. And then there are, again, some spillover effects. So if you think about kids who are citizens but their parents aren't, their parents understandably might have been reluctant to sign them up for Medicaid. If you're undocumented, you might not want to risk going into a state public assistance office and filling out paperwork describing your employment and your family status. Well, with the specter of deportation on hold, you might see more parents willing to come in and get their kids signed up. You might see more family members with adult relatives living with them who are undocumented now going in and signing up for the ACA. And this is, again, where information and outreach is key. For people to understand that, that signing up for their kids for Medicaid doesn't get them deported. Right? That's kind of information that's really important for people to have. And then the last kind of spillover effect here is really not to healthcare, but to health. And that's that we know deportation is not a benign process. Deportation tears apart families. It causes psychological and physical stress. It reduces the economic and social resources that are available to those who remain in the U.S. And so simply by reducing the number of deportations, which by one estimate is 400,000 in the past year, these are our families and households and communities that are not facing that huge physical, psychological, and economic stress. So that leaves us at this crossroads where I think there's a lot of progress and a lot of opportunity ahead, but it's an uneven progress that we've been making. Right? So we have by states, by legal status, disparities that remain and depending on how you view them, potentially worsening. But on the other hand, we have clear absolute progress gains for some groups and that we see reductions in the uninsured rate across the board and particularly in the Latino community. So there is real progress and it's a real time of opportunity. We have to see what will happen with the deferred action executive order, and it's not a replacement for comprehensive immigration reform. An executive order can be overturned by the next president, can be overturned by an act of Congress. A true comprehensive immigration reform that will undoubtedly be part of the upcoming presidential election season is really the most plausible way for the majority or all of undocumented immigrants in the U.S. to get a pathway to affordable health coverage. So let me wrap up by just showing you a quote from a book that I'm reading right now that I was fortunate enough to bump into Seth Holmes, who's an anthropologist and a physician at Berkeley, and he wrote an ethnography of agricultural migrant workers. You may have seen this book called Fresh Fruit, Broken Bodies. And I pulled a quote from the book that to me is just a really important reminder of how we think about context and how we think about the status quo. And what Seth wrote was, our lenses of perception match the social world from which they are produced. Thus we come to misrecognize the social structures and inequalities inherent to the world as natural. And I think for those of us who work in healthcare as clinicians, those of us who work in health policy as policymakers, those of us who work in community advocacy, we often see the existing disparities in the healthcare system and in our policies in general as kind of a given. And how do we kind of try to tweak around the edges and make things better? But it's worth stepping back and reminding ourselves that it doesn't have to be this way. There isn't anything natural about it. This is simply the system that's been created. And to whatever extent it's unjust, and in many ways it is, the status quo isn't an excuse for inaction. So I'll wrap up there and look forward to your questions and comments. Thanks again for having me. All right. So do we have a microphone that we're going to? Oh, okay, great.
Just to clarify, did you say that legal immigrants with green cards less than 5 years can sign up under the ACA?
Yes, so they can't sign up for Medicaid, but they can sign up for the tax credits on the marketplace. So yeah, legal permanent residents, doesn't matter how long they've been here, they can apply and get tax credits to buy coverage.
Thank you.
Could you talk more about the 40% of undocumented immigrants who are insured?
Yeah, that's a great question. That's, that's a statistic I show in my class, and it's always one of the students says, wait a second, what? 60% uninsured is high, but it's not 100%. Well, so this relates to a couple different issues. So one is through employment, that people can get coverage through employers, depending on their employer, whether that it's offered and whether they can afford it. And the other is that you can purchase insurance directly from insurance companies. And this gets more complicated under the ACA, and we were talking about this actually in the business breakfast roundtable we were having upstairs. But generally speaking, most products sold in the United States, regardless of whether it's health insurance or commodities, goods, buy things on Amazon, you buy a membership to a club, they generally don't require a Social Security number. Now, they can always ask, and some products do, but to buy an insurance plan, there's no requirement that you show that you're a U.S. citizen. Now, under the ACA, you cannot buy a plan on the marketplace without legal status. But directly purchasing a product from an insurance company off the marketplace, you can do. And pre-ACA, that was also, again, a pathway that some people used. Now, was it comprehensive insurance? Hard to know. Was it good coverage? Hard to know. And then some undocumented immigrants do qualify for forms of coverage that are state supported. For instance, the under CHIP, the Children's Health Insurance Program, there's a policy that's described as covering the unborn child. So an undocumented immigrant who's pregnant but their child will be eligible for CHIP can be covered for CHIP services during pregnancy. And some states, again, have set up local funding programs, and there's something called the Health Safety Net, for instance, in Massachusetts, which is not technically speaking health insurance, but functions almost as a form of coverage with a very narrow network for people. So, these are all based on surveys, and it's not always entirely clear what types of coverage people have. There's often some confusion or not willing to describe the details, but these are some of the various forms that people are getting coverage. And so it's not the case that 100% of undocumented immigrants have no coverage, but we know that the disparities are enormous.
Oh, I don't need that. How do you think that number would change if you included under 18?
So using the undocumented population under 18, I think that number does include children in that, but I'm not sure. Oh, it depends on which study. So the number I told you where I said that 60% of undocumented Latinos are uninsured, that does include children, that statistic. But the one here, right, didn't. So for kids, it's early. It's hard to say for the ACA impact yet, because essentially most of the federal government surveys that we use to track the uninsured come out 6 or 12 months after the data are collected. It takes a while to get them prepared. And so that means in the federal data being released, we're now just starting to get to the end of that first open enrollment. The numbers from this study I showed you come from a non-traditional data source. This is actually from the Gallup Daily Tracking Poll, because they do it really fast. The downside is it's not as good. The quality of the data are much worse. But they at least do a reasonably good job telling you whether someone's insured or not. And so that survey, unfortunately, only asked about adults. So we don't have good numbers yet on kids. My guess, and most of the projections are, we'll see some decrease in the number of kids without insurance through these spillover effects, through parents signing up for coverage because of the mandate. But it probably won't be as dramatic as what we see for adults, because most kids were already eligible for something other than the undocumented immigrants.
Thank you so much for your comprehensive talk about coverage. I'm Tina Cheng with Johns Hopkins, and I just wanted to ask, if you really want to get undocumented people covered, and you were talking to your legislator, your federal legislator, what would you focus on, and how would you make the argument?
Yeah, well, I think I would do a couple things. I think I would probably broaden it a little bit and not focus only on coverage, but focus on access to care, because some of the federal avenues to improving access to care for undocumented immigrants actually don't go through health insurance. So for instance, the federally qualified health center program and migrant health center programs do provide direct, comprehensive care, primary care services, and often dental services and vision services to undocumented immigrants. There's no prohibition against them doing that. In fact, they're required to take all comers. And so that's federal money that, that is subject to year decision by Congress as how much they're going to allocate. Getting that funding increased, especially, as we see the shrinking sources of other safety net funding, is really important. So that's one thing that's not through coverage, but it has really important impacts on access. In terms of health insurance itself for undocumented immigrants in particular, at the federal level, I think realistically it's about immigration reform. I don't think it seems to me, I'm not a political science expert. It's part of my training, but it's not my focus. But, I just find it very unlikely that given what we see going on with the ACA, even just in maintaining what it's currently doing, nearly impossible to envision a scenario where Congress passes a law that extends the ACA to undocumented immigrants. At every step, opponents of the law are trying to backtrack what it's already doing. So I think it's really through a pathway to citizenship and legal status that is the most likely way to get at a national level. At a state level, and depending on the political climate, it's getting the state to say, we're going to do this. We're going to fund coverage for undocumented immigrants in some form or another, whether we do it, through a tax on hospitals, whether we do it through, general revenues or a smoking tax or what have you, or a tax on the industries that typically employ undocumented immigrants. I mean, these are all possibilities. The states can do what they want. And at the state advocacy level, that's what we see going on right now in California. That's probably the most plausible path to getting coverage in the short term in the absence of kind of comprehensive immigration reform.
Hi, thank you for the conference. I had a question. I so confused. I have a question about for people who has the employer card authorization, they are qualified for Medicare?
I'm sorry, say it a little louder.
Yeah, for people who have the car employer authorization, are they qualified for Medicare?
If they have legal authorization, is that what you're saying?
Yes.
So so this is separate from the executive order. So legal immigrants, if they have paid into the Medicare payroll tax system, if you've paid in through 10 years of wage data. So I mean, each time when you get a paycheck every month, there's income tax, but then there's also the FICA and the Medicare tax, right? So this is Social Security and Medicare get pulled directly out of your paycheck. And if you have paid into that system, you qualify for Medicare when you retire. So if you're here legally and working, or your spouse is working, you can then qualify for Medicare. What happens to some legal immigrants who move here after they're done working is that they haven't paid in, and so even though they're legally in the U.S., they're not eligible to get Medicare. And so that's what happens. Now, they can get Medicaid if they have been, green card 5 years. That still applies. But that's kind of a niche of in the Medicare program that I think a lot of people don't realize, that you can be here legally and not get Medicare if you or a spouse haven't had any payroll history in the U.S.
Yeah, because,
and that might not just be because, I guess the other thing I didn't mention is you have to have either had employment and had that employment be on the books, right? Because if you're not paid on the books and there's no payroll tax deducted, you won't qualify either.
Yeah, because this week I had a consumer who he has the employer card authorization and he worked for more than 20 years, but he couldn't qualify for ACA because this year he just turned 65. So he doesn't qualify for ACA, and then we called to the social benefits for him, and they told us that he's not qualified because he has only the employee card authorization. So the other solution, I don't know what is the other solution for him, because he can get a Medicaid for him.
So it's hard to know what the specific details, but in general, for someone 65 and over, you're right that they can't get ACA coverage. They have because they're required to go into the Medicare pool. And if they're here legally and they had paid in to payroll taxes, they should be eligible for Medicare.
Yes, but they
So I don't know exactly what was happening.
And also we called to the social benefits, and they told us that he has to be a citizen to receive the Medicare. But it was not fair because he's paying more than 20 years, all the year to pay the taxes, but he didn't receive this benefit.
It's absolutely the case that many people do pay into the federal government and state government through income taxes and in some cases payroll taxes, and are still ineligible by legal status, right? The notion that immigrants are only taking out of the social service system is not true, when in fact they're often paying taxes, in some cases voluntarily paying taxes, that then they don't get to benefit from when they need social services. So maybe we have one more question time-wise, or?
I got it.
Yeah.
I have a question regarding medication, because a lot of undocumented patients, they have access to healthcare, but then they get prescriptions. Before the Affordable Care Act, pharmaceuticals used to send the medication like insulin, for example, to patients. And it didn't matter if they were undocumented, but it seems like that's changing now. Do you have any information regarding that?
So do you mean like free samples and discount programs from the pharmaceutical companies?
Like free insulin, free, yeah,
Yeah.
like expensive medication.
Yeah. So those have never been kind of required or funded or directed by the government. That's always been, essentially a marketing tool that drug companies use. I would say that sometimes maybe it is truly motivated by altruism, but most of the time it's, if we get this into doctors' offices and we get patients on this, even if that patient can't pay, the doctor will keep using it. And studies show that that's probably true. And it also is that at some point that person might get insurance and then they'll want to stay on this product. So insurance companies, pharmaceutical companies can stop that at any time because they're just choosing to do that. I don't know whether we've seen a change. It's a good question. It's whether that practice has become more or less common in the era of the ACA. It's a great question. I don't know, and it's certainly possible.
We have time for one more question.
Okay. Hello. So I was just curious, do you have any data that reflects that undocumented immigrants have progressed to an illness severity that's progressed to a level where they end up in the hospital? And is this a reflection because there aren't preventative measures or outreach programs that aren't getting to them? And if so, is that costing hospitals more?
Yeah, it's a great question. It absolutely happens sometimes that people are not getting the preventive care we want them to and that they get sicker and end up having more expensive treatment. I'll say in the aggregate, when you look kind of at the population level, generally covering people, giving people health insurance is not a money saver. And that's one of the challenges, right? If it were a money saver, if we earn back if we put in $10 and got back $20, this would be easy. Everyone would be doing it, regardless of immigration status. The challenge is that you're paying for a benefit. You're paying for people to have better access, to get better care, to have better health, to live longer, and to have a more just healthcare system. And while you avoid some costly complications down the road, overall, it tends to be easier. It tends to be cheaper to not cover people. The cheapest healthcare system in the world is the one that locks its doors to its patients. That's a line I often say. And that so what we're talking about here is making an investment. And upstairs, we were talking about what's the business case for expanding coverage. Well, the business case, I think, is getting a healthier workforce, a more productive workforce, and encouraging businesses to locate in a place where they're going to have that, where they're going to have a healthy workforce. They're going to have a workforce that knows that if there are complications either of their job or separate from their job, medical problems, that they can get treated for it. But it's not free. It's not going to be cheaper to cover people than to not, and that's the big challenge. And I know that it's often tempting to say if we cover people, we'll make all that money back and in troves. There's no evidence that happens, unfortunately. We get better care and people do better, but we do have to pay something for it. And figuring out how to do that and to muster the kind of political and economic will to do what we need to do to have a just healthcare system, that's the big challenge. Well, thanks very much.